Hello, everyone. Welcome to Queer Lawyers Speak, hosted by LAGBAC, Chicago's LGBTQ plus bar association. My name is Adam Zebelian. I'm a partner at Schiller, Ducanto, and Fleck, where I practice family law, and I'm also the current president of LAGBAC, Chicago's LGBTQ plus bar association. Today, the topic is the legal attacks that are currently happening against our transgender and gender nonconforming community members. And here to talk about that subject is Greg Fosheim. Hi, Greg.
Hey, Adam.
Can you introduce yourself to the audience, please?
It's my pleasure. Thanks for the invitation to speak. My name is Greg Fosheim, like Adam said. I'm a partner at McDermott, Will & Emery. McDermott is a global law firm. We are headquartered here in Chicago, and my practice is in the healthcare group. My specific practice areas involve clinical research, clinical laboratories, kind of the operational side of healthcare. And for the past really 3 weeks or so, I've been almost eyeball deep in gender-affirming care. We work with a lot of hospitals and health systems across the country to address the executive orders and how the delivery of gender-affirming care has been challenged. So it's been really a privilege to speak with hospitals about these topics. I also co-chair our LGBTQ Justice, Diversity, Equity, and Inclusion group, and I work throughout the city with many different LGBTQ organizations as a volunteer or as a board member. So that's a little bit about my legal background, but I know we'll dive more into that as we go along.
Absolutely. And before we get into your recent work in really analyzing the executive orders that apply not only to our community, and as a community member, it's important to you, but also as a practitioner because your clients are impacted by these executive orders. Before we get into that, tell us a little bit about your path to McDermott, Will & Emery, which is a very large global law firm, and how you picked healthcare law.
Yeah. So I'm one of those second careerers. I grew up in very rural South Dakota. As a child from South Dakota in the 80s and 90s, I didn't know what options were out there for me. I always thought that I was going to be a doctor, but going to undergrad in Iowa, I realized pretty quickly that I didn't want to be a doctor, but I didn't know what that meant. So my senior year of college, I threw a dart at a map, literally, and Atlanta was the closest location to that dart. And okay, guess I'm moving south. And Emory, the School of Public Health, made sense with my degree background.
Were you pre-med?
I was pre-med biology, yeah. And so I enrolled at Rollins, the School of Public Health at Emory, and focused on epidemiology. Getting into that world was brand new to me. I didn't really have any public health scientists in my family, but it had always been kind of an interest and a passion. Now this is August, September of 2001. Remember that date. So I went to Emory's School of Public Health is across the street from the Centers for Disease Control. And a friend of mine said that there's a work study position at CDC, and so I applied for it. They invited me for an interview, and I pulled up to CDC's front door, and I wasn't admitted. I wasn't allowed in. On my trip from South Dakota/Iowa to Atlanta, I had hit a deer. So my car didn't have radio. I had no idea what was going on. And when I got to CDC, they said, no one's being admitted today. It was 9/11. So I got back in my car, I turned around, went back home, and had a new interview for a work study position the following week. CDC was overwhelmed with response to 9/11, with fears about Atlanta being targeted next, and basically I was
for potential biological war.
Exactly. So I was basically hired on the spot to be a work study student in the Staff Aureus reference laboratory, the National Reference Laboratory. my colleagues were busy responding to anthrax. When all the Senate office letters were being sent, they were being processed by my colleagues. And so I was this 22-year-old with a bachelor's degree handling the nation's staph infections.
Wow.
Just kind of this fascinating confluence of circumstances, and I enjoyed it. It worked well with what I found myself kind of drawn to. It converted into a full-time position, and
this was while you were in grad school.
this was while I was in grad school. Yep. So I graduated with a master's in public health as a full-time CDC employee. Fast forward 10 years, I realized I don't really have the right degree combination to be a benchtop microbiologist. And that's about that during the time that's roughly when the Affordable Care Act came out. And so I saw this.
2008?
Yeah, 2009-10 was when I started having those conversations with myself. Obama was inaugurated in 2009.
That's right.
So most of my benchtop career was in the Bush administration.
What do you mean benchtop?
My
Research?
working with as a federal employee on research on microbiology, and I was also reviewing a lot of HIV grant applications. Interestingly, at the time, nothing was fundable that had to do with condom usage. It was only abstinence and being faithful. And all of that, combined with the Affordable Care Act passing, kind of made me start to realize that there is a role for healthcare fluent queer individuals to enter law. The enactment of the Affordable Care Act then kind of gave that that permission, for lack of a better word.
Interesting.
Why? Because
what was it about the act that made it more inclusive in that space?
it was 1,000 pages that no one knew anything about. So when I talk with law students, I always kind of encourage them to look for areas that no one else knows anything about. Then you're starting at the ground floor. Other lawyers may have some ideas, may have the ability to extrapolate, but if it's a brand new law that no one has addressed before, you can be first. You can start to think about how this applies to this client and this industry and be thought leader early. And that's kind of what I thought that, all right, I'm early 30s, I'm changing my career, I should at least do something that isn't saturated. And so went to...
Like being a divorce lawyer. Just kidding. Just kidding. There's always a
the
need
numbers
for...
are going up. So yeah, I went to law school knowing that I wanted to be a healthcare lawyer. I did kind of dip my toe into IP, being a scientist, but one Markman hearing was all I needed. And
I don't even know what that means.
That's a long federal hearing about the definition of a word.
Okay.
And
that would
although I can be very semantic, it was not very.
that would have
it
driven
was
me
not
crazy,
super
too.
interesting.
Yeah.
So anyway, that was my pathway to healthcare. I knew I wanted to practice healthcare. There are several great healthcare law firms in Atlanta, and I joined one right out of law school.
Now, did you go to law school in Atlanta?
I did, yeah. I went to Georgia State in Atlanta, which has a great healthcare program. So got to learn very hands-on. I also, Georgia State is in downtown Atlanta, and it was at the time maybe 2 or 3 blocks away from the Capitol building and the federal courthouse. So I would often, on my time off, just go hang out at the courthouse, listening to oral arguments, watching different practitioners practice. Again, I didn't have any lawyers in my family, so I felt like it was on me to learn what the discipline really looked like. And it was, I think it's made me a much better, more well-rounded lawyer to kind of understand what the courthouse looks like. I'm 2-0 in my courtroom career, having said 3 words, yes, Your Honor.
And you won?
And I won.
Okay.
So I'm doing well there. But I'm really a behind-the-scenes operational lawyer where it helps to see how the sausage is made.
Right. So you don't litigate.
I don't
You're
litigate.
a transactional attorney.
Yeah, I'm a regulatory attorney.
Got it.
Which means, yes, I will support a transaction. Yes, I will support a litigation. But by the time we get to litigation in the healthcare space, it's not great.
Right. It's pretty bad.
Yeah, we're not in good shape.
Yeah. It's better to let other people deal with
Yeah,
that mess.
exactly.
Okay. Very good. So let's talk about these executive orders, because as a regulatory healthcare attorney, these orders are impacting your practice,
That's
I'm
right.
assuming,
Yep,
and impacting your fellow community members.
that's correct.
And recently, I saw that you put out, along with another lawyer,
Yep.
a summary of what's taken place in such a short period of time since Trump took office.
That's correct.
Can you tell the audience what has been taking place?
Yep. So like I said, one of my particular areas of expertise is in the legal aspects of gender-affirming care.
And what is gender-affirming care?
Yep. So gender-affirming care clinically is whatever clinical and medical and mental health care services are needed for a person who is experiencing gender dysphoria, or those who may not necessarily have a clinical diagnosis of gender dysphoria, but are gender non-conforming, non-binary, or somewhere on the transgender scale. So what gender-affirming care is everything that's needed to really help a person to be comfortable being who they are. It could be mental health care, it could be access to medications, it could be surgical care. Under the executive orders, though, it's a much different definition. The executive order that Trump signed considers it to be the chemical and surgical mutilation of an individual. It's very aggressive language, and it's limited to
And they define it in the orders.
They define it in the order using the term chemical and surgical mutilation of individuals under the age of 19. So a lot of things to unpack with that definition. It applies to puberty blockers. It applies to hormone therapy, cross-sex hormone therapy, and it applies to surgeries. Interestingly, though, by having it apply to up to age 19, now we're taking the ability to consent to medical treatment away from adults. And now we get into a bit of forcing practitioners, forcing physicians and other providers to take away the right to self-actualization for consenting adults.
And also, and I don't know if you know this or not, but I'm assuming you probably do. I know in divorce practice with minor children, after a certain age, and I believe it's 13, they have a lot of control on what's disclosed with regard to their health care.
That's
mental
exactly right.
health and pphysical health, to their parents even.
Yep.
And so that really takes, it also limits that ability too.
Absolutely.
Of a 13 or older child to consent to medical care, plus the 18 and up.
Yeah, that's exactly right. And using your divorce analogy, there's also some states that are using a single parent consent when the other parent opposes as grounds to take custody away from the consenting parent if the state happens to have a state prohibition on gender-affirming care for minors. So there's a lot of nuance to the provision of care. And in my practice, where I'm representing hospitals, health systems, providers, why this is challenging is because many are well-established gender-affirming care practices and clinics where people come from across the country to obtain that care. But the executive order conditioned all federal research and education grants on the cessation of care. What that means is that, as written, if a hospital health system continues to provide gender-affirming care, they could be at risk of losing all federal grant funds related to education or research, irrespective of whether those funds are for gender-affirming care.
And just so the audience has some context, any given hospital, how much of their funding comes from the government?
A lot.
A lot,
Yeah.
a substantial percentage.
A lot, yeah. And if we go to another component of the executive order, the hospital also could be at risk for losing Medicare and Medicaid enrollment. And that, for almost every hospital in the nation, would shut them down.
Wow.
At least 30% of funds comes from Medicare and Medicaid for a hospital. Most is more like 60 to 70.
This is fascinating and disturbing.
Mm-hmm.
But as you're going through this, and I hate to derail you, I have questions.
Yeah.
Who's enforcing this order?
It's right now not enforceable. An executive order is not on itself self-enforcing. And what the Trump administration has done is so there's two lawsuits that are currently in the works to challenge the executive order. One is out of Maryland and one is out of Washington. And in the Washington case, the Trump administration admitted that they have not taken any steps to condition or withhold any federal grants or monies. Now, we also know from other executive orders and TROs, temporary restraining orders that have been filed, that's not true. They have withheld funds, so that kind of
From hospitals?
From everyone, from federal grants. Federal grants have been withheld, and a order came out of the district court of the District of Rhode Island telling the Trump administration they had to stop doing that.
But their argument is we haven't done it, so the issue's not ripe
Exactly.
to be in front of the court. Wait till we do it, then sue us.
That's
but right now we
exactly
haven't
right.
done anything. We just issued the order. And they're saying, no, you have.
That's correct.
Got
and
it.
similarly with Medicare and Medicaid enrollment, that no one has challenged that component yet, because in order to change Medicare and Medicaid rules, you have to go through what's called notice and comment rulemaking, which is a lengthy process that usually takes at least 6 months. And the government has to explain what they're proposing, why it may be a change of policy from prior years, and give the community, the public, at least 30 days to respond, to give comments, to give suggestions, and then the government has to respond to each of those comments. In some rules, you may get 2 comments. In other rules, one that very intimate to me that I work very closely in is Section 1557 of the Affordable Care Act, which is the non-discrimination provision. 70,000, 80,000 comments are usually submitted for every iteration. So in order to get through all of those comments, you have to be very intentional about reviewing them. And if the government is not intentional about reviewing them, they can be set aside for an arbitrary and capricious argument, meaning that they did not follow the Administrative Procedure Act. And
Meaning if they haven't reviewed every single comment,
correct.
the court can interfere.
That's correct. By saying
intervene and prevent the amendment or from going through.
That's exactly right.
Okay.
And we're also now in this world, may have heard about Loper-Bright, which was a decision that was issued by the Supreme Court last year that takes away deference to administrative agencies. In the past, we were under what's called a Chevron doctrine world, where whatever the agency said, they were the experts, and courts would just defer to them. Now in this Loper-Bright world, the same deference isn't automatically granted to agencies. So they have to be very precise about what they are saying, and it has to be in line with the authority that's delegated to them by Congress. Whether Congress intentionally delegated to the Department of Health and Human Services the ability to change Medicare and Medicaid conditions of participation based on a hospital not providing gender-affirming care, It's untested, so it's certainly going to be challenged. And what we're trying to do is educate hospitals about what their options are. What would it look like to cease providing gender-affirming care in a state like Illinois, where we have robust protections of transgender individuals? The Illinois Civil Rights Act prohibits discrimination on the basis of sex, and sex includes gender identity, gender expression, and sexual orientation. So if a hospital would be providing, let's say, hormone therapy for a child who's experiencing precocious puberty, and they are giving a puberty blocker for that purpose, but not for a transgender child who is experiencing gender dysphoria, that may be a violation of the Illinois Civil Rights Act. And Attorney General Kwame Raoul joined 14 other attorneys general issuing a press statement saying, we strongly encourage you not to preemptively comply with the executive order because, as I said, the government itself has said we are not conditioning any funds. No Medicare enrollment rules have changed. This is kind of just cage rattling and a paper tiger. But I think everyone knows the Trump administration has not been all that adherent to the rule of law. They haven't necessarily been following precedent, and the Supreme Court may or may not be the last straw to save what we've grown accustomed to. And that's what providers are really navigating, because as we talked about, losing 60% of your funding would close the hospital.
Right. So your clients, as a lawyer, not as a member of our community, but as a lawyer trying to protect your clients, it must be very difficult to advise them because if they take path A, they violate state law. If they take path B, if they take path A, they violate federal. If they take path B, they violate federal law.
Yeah. It's
while
very
complying
challenging
with state law. It's one or the other.
It's very challenging, particularly because you can see the agony. And I think that's what I want to really reiterate, particularly to anyone who may be trans or non-binary or gender non-conforming. Hospitals care. People really don't want to be taking these rights away, but it's very much a Hobson's choice. There's no good possibility. There's no good outcome. And that's what we're trying to do, is really give options, help to weigh the risks. Many hospitals have retracted their decision to stop providing gender-affirming care because they're understanding that the executive order is not self-effectuating. And so they're returning to providing that care, and we're working with them to figure out options should these executive orders go back into effect and become the rule of law. What are your options? How do we ensure continuity of care? How do we make sure that we don't risk patient abandonment? Is that going to be referrals to other community providers in the community? Is that going to be setting up unrelated entities? What is that going to look like?
So when you say hospitals have retracted their stop of providing this gender-affirming care, is that nationwide or really only in Illinois because there's so many protections for transgender individuals?
It's individual decisions. Some Illinois hospitals have, some have not. Some California hospitals have, some have not. We're working really with hospitals across the nation, and it's a conversation that is just like the conversation with a family who has a child who is seeking treatment for gender-affirming care. It's individualized. There's different risks. There's different decision points. There's different calculuses that are really important. And it's, like I said, a privilege to be part of those conversations, to have the trust of the hospitals, to have the trust of the community, to speak on behalf of the needs of transgender individuals as someone who is not trans myself. It's kind of that, to get on a quick little soapbox, I think it's the responsibility of the cis white affluent male to step up. It's our turn.
Right.
We have a little bit more latitude to stick our necks out than other people do, and if we aren't all marching together, then what's the point?
Right. Very well said. Well, we could talk about this for an hour. But I ask every guest, well, actually, we could talk about it all day. This is really an important subject that needs to be fleshed out, and people need to know about it.
Right.
Because it's so complicated, but no one really tells you exactly what is happening.
Correct.
No, when you listen to the news, you hear these executive orders being issued, but you don't actually know
What
the
do they mean?
mechanics
Yeah.
of it.
Yep.
So that's why you being on today is so important and so helpful. So
Thank you.
thank you. But I do want to get on a different topic because everyone on the show does this. What's your coming out story?
It's pretty boring. Like I said, I'm a farm kid or a rural kid from South Dakota. I grew up in the Matthew Shepard era. Matthew being from Wyoming, me being from rural South Dakota. I saw a lot of parallels. So I did not come out until after college. I had a 1 year of being an out single gay man in a new city until I met my husband and
In Atlanta.
And we've been together 22 years. So coming out was just kind of well, this is Mark and these are my parents and here we go. So there isn't much to it. It just was going from single gay man to married suburbanite real quickly, and then having someone next to me to come out with professionally, to come out with to family, to come out socially, was just very, very gentle, very, very easy to do, and it's helped me to try to be a mentor for other young queer lawyers, young queer professionals, and to try to give as much back to the community as I can, because it's a community that's really been there for me.
Well, thank you so much, Greg, for coming on. You've been excellent. We need to have you come back.
Okay.
Because this is going to be an ongoing conversation, unfortunately.
Yep.
So thank you so much.
It's my pleasure.
And
thank you for listening.
Yes, and we will see you all soon. Thank you.